Hello. Actual electric microphone. That's your chair. So hello, welcome. My name is Matt Wren. I am the co-founder and chief technology officer of Untitled, which you've probably seen some demonstrations from tonight. I'm also the founder of the VRAR Chicago Meetup and the Chicago chapter president of the VRAR Association. This meetup's been going for a little over 2 years now, pretty much growing every month. We try to focus on an industry topic. Just out of show of hands here, how many of you are from the healthcare industry? Don't be shy. We had a lot of people, like everybody from retail last month wouldn't raise their hand, and then there were like 20 people afterwards who were like, well, I'm from retail, but I just want to be the only one. So cool, we have a lot of healthcare people. How many people are actually VRAR like technology folks, specialists? So for all of you healthcare people, raise your hands. Keep them on, guys. Come on. Part of the whole reason of being here is networking, actually meeting people, talking to people, and getting your questions answered. I'm going to start with some sponsor messages because our sponsors help us keep this running. So we will start with John from Model AR.
Thank you. I don't know if this is on well.
Oh, that always helps.
I think it's on better now. Thank you. Tonight is special for us on many levels. One, I have one of my very first contacts in media when I was calling on Marshall Fields when I was with ABC many years ago at WSAM and FM and WDAI. Gloria, where are you? Would you at least please say hi? Thank you for coming out tonight. I also wanted to let you know, because of Matt's leadership with our technology team and our company, that we are building out an augmented reality platform to serve the community. So please talk to us if we could be of service to you in any way. But I also want to let you know we're growing, and we're looking for a project manager to assist in our growth. So if you know of anybody, please let us know. Other than that, I'm going to say thank you for all of you for coming tonight and educating and sharing. And Matt, thank you for showing your nonstop leadership in this space. So thank you.
Excellent. Up next is Ramita from VRAR Association.
I'm the VP of Strategy for the VRAR Association here in Chicago. Just quickly around the room, Mark, John, Paula, can you raise your hands? So this is our team that has worked really hard to put this event together and puts these events together every month along with Matt's leadership. I want to call them out and also let you know who they are. So any questions you have, if you're not a member, interested in learning benefits, interested in getting involved in volunteering, come talk to any one of us. Even if you're interested in not being a member, but just finding out how we can help you. Our vision for the organization is to create an ecosystem here in Chicago, connecting startups, companies, the volunteer groups, the NGOs, everyone, creating a resource here so Chicago can really lead the pack in the technology. So thank you all for being here. Come talk to any one of us if you have questions. Thanks.
Okay, so quick show of hands. How many of you have been here before? Wow, a lot of repeats. Let's do this easier with that. How many of you have never been to one of these events before? Okay. So to put it simply, this event is about you getting your question answered. Whatever you're looking to do with this technology, whatever the next step you have to take forward is, try to do it tonight. That's the whole point of this. We are streaming live, just be aware. This is, we've tried to do this a couple times. We're doing it again this time. Hopefully it works. It's going to Facebook Live on the VRAR Chicago page. That said, we have a whole panel, a ton of experts here in the healthcare and VR and AR space that are here to answer your questions. So I'm going to start by letting them introduce themselves. I guess there's going to be a demo, which we're going to show you this time as well. So we'll start with the end and work our way this way.
Hi everybody, my name is Hunter Lane. I'm a product director at Tempus, which is a healthcare startup focusing on precision medicine, and specifically cancer.
Hi, my name's Erica. So I work as like a VR developer, and I also do a lot of 3D modeling. some technical questions. And I contract with Tempest, and I also work with like a small group at MIT, and we just try to create new haptic approaches for VR.
I'm Eric Yelker. I'm a practicing.
Keep it close to your face.
I'm a very loud person, so. So I'm Eric Yelker. I am a physician and an educator. I have a master's in medical education, and my focus was on educational technology. I work as the vice president medical director of Level X, which is a local startup here in Chicago that makes medical mobile video games for physicians. And we do stuff mostly mobile, but also do VR and AR for our different experiences.
My name is Carter Egan. I'm the technical director for Immersive Touch. We are a startup out of UIC. I basically do all the AR and VR development. I'm involved in all of it. Been doing it for about 4 or 5 years. And yeah, happy to answer any question.
Good evening, everyone. My name is Jia Luo, and I'm the Vice President of Immersive Touch, same company as Carter. So our company has been in the field for like about 15 years, and we're working with several applications in surgery trainings and surgery plannings, patient engagement, and so forth. And later today, we're going to give you a bunch of demos and then some talks, and also we're open to other questions. Thank you very much. Nice meeting you guys.
Do you guys want to do your demonstration now, or do you want to wait?
We can just wait, I guess.
Okay.
Up to you.
Okay. Of conversations rolling, I don't want you to miss it if we're going to do it. Okay. So, the way this works is real simple. This is audience Q&A. I do have a couple of questions for them in case you guys don't have any to start with. But we have Ben over here on the side who's going to be doing some microphone. Victor, where are you at? He's on that side. So ultimately, if you have a question, get someone's attention. We do want questions going into the microphone so everybody can hear. Again, we actually have this streaming, so it's helpful for the camera if the microphones can hear it. Anyone want to volunteer and be the brave one to actually ask the first question? Just raise that hand up high. In the back. Okay. Hang on a second. Victor?
Should we start out here?
Yeah. He's back there.
Hi everyone. How far off are we from having surgeries performed long distance in virtual reality?
Alright, since I have a microphone. Yeah. So I think, the long distance or remote surgeries depends on like several different components. Virtual reality is a good interface for the surgeons to operate in remote. And we do need to have like a pretty good robots on the patient side. And I know that Da Vinci has like a pretty good remote surgery systems. I also know there will be like a bunch of lawsuits against him. So I don't know if the technology is really there. And in the meantime, the communication in between these two are another critical part. Like I know that the 5G is coming pretty soon, and then that will probably make the communication much better. But as of right now, I guess the latency in the network could be a bottleneck of this. Yeah, please.
Yeah, I agree. Lag and connectivity has been the biggest thing. Intuitive Surgical already does remote surgery from the room next door. The question is, can they do it across the country, and then can they do it across the globe? The scary thing is that a lot of times in surgery, reaction time is extremely important, and any lag that you have, or any poor feed, which we already have in the same OR right now. I have equipment breaks constantly, and it's not over 5G or 4G or anything. So we have a lot of technical things to solve before we do global surgery remotely.
Good evening, everyone. Here's a question about regulatory compliance. I work with device manufacturers as well as pharmaceutical companies, and obviously regulatory compliance is a huge thing, especially if you're a startup. You may have a great idea, and when it comes to mobile apps, or in this case, augmented reality applications, there's a fairly high hurdle, though, that you still have to jump. I'm curious what your perspectives are with respect to what do you see as the biggest issues for getting your solutions on board with regulatory regulatory compliance?
So we've actually been asked this question before. From Level X's standpoint, we are a video game that is free and people are able to practice. We make no claims about how whether it certifies anybody to do surgery. Now, there are some point-of-care solutions that have to go through that FDA hurdle. In fact, there's been some companies who just got FDA approval last week for surgical planning and intraoperative use. So I think augmented reality and virtual reality is already in the OR and it's already being used. And they have to go through the same FDA process that any other device has to. They have to prove that they're safe and they're efficacious. But obviously the 510K process is very different now than it used to be. And so I'm sure some people used to go through that process before, but it's going to be, those loopholes are closing very quickly.
I was going to say FDA.
Hi. One of my main interests in VR is the evolution of virtual desktop, having just being able to have unlimited screen space and having Windows be all on my face. For me, what seems to be the main stopping point, or excuse me personally, from going after that is I'm still tied to a physical mechanical keyboard. So for the haptics, guys and ladies among you, how close are we to having something that simulates a keyboard would realistically allow me to type in midair?
So I haven't seen anyone make anything like that, but I think if someone was making it, I bet it would be like one of the more major tech companies. I think everyone here is probably focusing on like surgical instruments. I don't know, do you guys know anyone making a keyboard?
I mean, I've definitely seen keyboards. The popular thing to do is make them huge in front of you, and then you have a controller. It's got a big ball at the end, and you tap away at it. But I would say the main advantage of VR, at least for us, is to get away from the keyboard. I always say that immersive view, which we can hopefully demo so you guys know we can do other stuff besides ball games. I say it's like the easiest piece of medical software to ever use, right? If a surgeon wants to use traditional 2D, any kind of like 3D modeling software, there's a million different commands and hotkeys and right click and center click and all that. Where we sell immersive view as like, pick it up and use your hands, and in about 5 seconds, you can use our software, right? So I agree that a keyboard would be very helpful for very, very intense kind of like tasks, but kind of what we're doing is trying to make it not so intense to use.
As a clinician, we're all waiting for Minority Report to happen.
Yeah.
So there already are some holographic keyboards that already exist. The gesture control, I think, already exists. I know the MIT Media Lab is working on stuff with that. So gesture control is coming. So the question is again, when you're looking at the operating room, the stuff that we have that plugs into the wall fails. We have a huge hurdle from a technological standpoint to get these into the operating rooms and get these into the clinics, because we can't even get Wi-Fi to work.
So I'm actually going to differ from all of you guys. Have you seen any of the virtual keyboards, aside from the actual a VR keyboard where you're typing, which you can do that in an Oculus Rift. I mean, it's used with pointers, so you're basically just doing this. But with the auto-completion that happens on it, it's pretty quick. Like, you can type almost as fast as you can type on a regular keyboard. That said, have you seen the glasses, the North glasses, they have the ring, where there's a ring with a little joystick on it to press, and you use that for your input device. And then there's the tap, I don't know if anyone's seen that, which is basically a set of bracelets, kind of like 4 rings that are attached by a thing, and you type by doing this. But you have to learn a new way of typing. So it's not just like typing on a normal keyboard, but this might be A, this might be C, and it's just combinations. Within about a day, you end up teaching yourself to type just as fast as you can on a keyboard. The other one that I've seen, which I've only seen once, and I can't say where I've seen it, but it was very Minority Report, we'll go there. But it was a set of gloves where the keyboard was doing this. So I've seen 4 or 5 different ways of people trying to do effectively keyboard input without actually having a keyboard. And that said, the fastest way I've ever been able to type when in VR is to just have a keyboard on my lap that I can't see. Which you don't realize how for those of you who use a keyboard every day and look at the keyboard and you think you have to look at it to type, until you literally have an Oculus in front of your face and you can't see it, you realize, oh, I can still type without seeing it. You know, so I remember they used to train people like typists. You said go to classes to learn how to do that, and if you don't realize how quickly you can actually do it yourself if you've been typing all day. So there's lots of options. But yeah, I would agree that ultimately the goal is let's just get away from the keyboard, because ultimately this is pretty inefficient for transmitting
Except
information.
for programming.
Well, if you're a programmer, yeah. Which is what I was doing in VR, which is what I had. So who's next? Oh, here we go. We're next.
Hi, I'm an interaction designer, and I'm wondering in terms of the interaction for VR and AR. Currently, a lot of it looks like we're trying to imitate as much as possible to feel real and to feel like things that already exist. And I was wondering, how are we doing in terms of designing so that the interaction is sort of getting rid of the things that we don't have to pay attention to and focusing on the things that we do and maybe augmenting that instead of just always trying to be as close to reality as possible.
I mean, there was a lot of skeuomorphism with phones, like just a touchscreen phone. And obviously, a VR experience is going to be orders of magnitude more different than anything we're used to. So I expect it will lean pretty heavily on real-world metaphors until it becomes more ubiquitous, which I don't think is that far off with the current generation of headsets that just came out. Having said that, I think there's also a lot of other cues that lead to interactions that are unique to VR. For example, Cat Explorer is the demo that comes to mind. There's a little knob that you use to adjust the scale of a cat. I won't go into the whole thing. But putting your finger close to it, it reacts and it's almost like your finger's magnetic, and it pulls towards it and it hums and it glows. And because you don't have as many visual cues for depth perception, you really need all of that. And all of that's unique and it's novel to VR, and I think we'll see a lot more things like that that are harder to come up with than just skeuomorphic approaches.
I was at the Game Developers Conference in March, and there's a whole section called Alt Control. That is, has anybody been to GDC before? So did you guys check out Alt Control? You should. It's pretty awesome. So basically, they use a totally abstract human-computer interface to interface with the digital environment. One of the games was a railroad game where to propel yourself forward, you actually shoveled coal, which was actually basically just ping pong balls. And then you had to shift back and forth to change lanes. It was very cool. There was another one that had a cooking game that actually had a simulated kitchen in front of you that was all electronic and magnetic control. Alt Control is really cool, and so some of the really cool stuff that we're seeing in technology, I think the games industry has a lot to offer because they're really sort of way thinking outside the box.
The only thing I'll say is, it's tough in the medical industry to do really kind of like cool and advanced like gesture-based stuff, because our primary user is someone who has probably never played a video game in their entire life and certainly has never tried VR. So our joke is we use Fisher-Price UIs, just as simple as humanly possible, so that the same thing with the manipulations. Like once you pick it up, you don't have to learn a bunch of like shoveling coal, which is cool, but it's something that would frustrate our users, and then they would probably just give up. And that's the biggest hurdle we have as making video games for surgeons is if they can't do it in about 30 seconds, they're just going to give up and it's over and it's done. You're out of the hospital then. So while that's all really cool for like games and stuff, it's just in this industry specifically, it's just don't make a desktop window, right? That's what I see a lot of competitors do. It's like it looks like Windows, and and there's a bunch of little buttons, and the resolution and headsets aren't great, so just big buttons, this does that, and we can allow you to do surgeries with pretty simple input. So it's definitely just a kind of a different beast making VR for medical professionals.
I'll agree. I mean, physicians and surgeons are very much traditionalists. But we have a whole world of digital natives that are growing up as physicians that are pushing the envelope. This is a company, we really talked about skeuomorphic versus non-skeuomorphic controls a ton. In fact, one of our games just went over complete redesign from a skeuomorphic to a non-skeuomorphic control. And because we are trying to understand the physician, and exactly as you said, a lot of them are very much traditionalists. They're like, why would I do this when in the OR I'm doing this? And it's because, well, you don't have to do that, and especially for us because we're a touch screen. But I think very much to his point, but I think it will change over time as more and more digital natives are coming into the healthcare industry and as physicians, surgeons, and just like when laparoscopic surgery came to medicine, no general surgeons want to do laparoscopic surgery. I'll tell you, there's not a surgeon on earth that doesn't want to do laparoscopic surgery if they're not already doing it because it's the standard of care. And so that's what's going to happen over time is those physicians are just going to be removed because they just can't keep up with some of the stuff that's coming out.
And then, sorry. I was also going to add that I've noticed as well when I'm working with surgeons and talking to physicians and getting feedback about applications, the amount of medical data that you need to have inside the application is just such a large amount. The amount of feedback you want to be getting, that can vary depending on the different kind of surgery you're working on. And having like a really complicated interface kind of takes away from the most important aspect, which is just practicing the surgery and then getting a lot of feedback about whether or not you're doing it correctly or getting good feedback, good data from like your procedure. Yeah.
I think you may have just answered my question, but I've worked with surgeons my entire career, and I completely agree with what you both said. You got to keep it simple. But that's for the surgeons that are my age and younger. Do you see this next generation of residents and fellows adapting to this stuff much quicker? And are you like anticipating that in your design work as well?
I would just say definitely. It's kind of VR as a whole. When I started back when I was in Milwaukee doing very early VR stuff, it was for architecture, which is another very popular way to use VR. And I would go in and all the young architects and designers would love it, but the old guys were just like, we've been drawing on paper for like 50 years and that looks great, so let's just keep doing it like that. But it's definitely, obviously, the younger generations coming up, and I wouldn't say we're honestly like planning for them to take over anytime soon. We're still trying to make the bread and butter of like the math, the age of most surgeons, I guess. So it's definitely going to change, and that's when you're going to see it in everyday life. It'll change when society says let's all wear AR glasses all the time and look at big fake TVs instead of real TVs. So
I'll just add to that. I think, again, there's a lot of traditionalists that live out there in the medicine world. Realize that people are graduating medical school right now were born in 1994. And so when they're joining the healthcare industry, a lot of times what ends up happening is the residents and fellows push the attendings to sort of push out their comfort zone. And I will tell you that, whether you believe in millennial learners or not, there's a much harder onus on people that are older within the physician realm training the younger generation. And so there's a lot of back and forth that's happening between there. Also realize that there's some other factors that are actually really pushing this industry. One is older physicians no longer have the financial reimbursement that they used to have, and so a lot of them are actually looking for other revenue streams and are actually leaving the healthcare industry much faster. Unfortunately, there's a lot of burnout that's happening in healthcare, and people are going into the tech industry and biotechnology because they can use their skill set in those other areas. And so a lot of the Luddites and a lot of the traditionalists are actually probably leaving for the most part, and we'll see that trend more and more as more junior people come up. The last thing is that surgery actually is using heads-up displays in AR and VR, and so because of a lot of operating room injuries related to cervical spine, and so a lot of the stuff where neurosurgeons used to use microscopes and a lot of other surgeons use microscopes, there's been a lot of cervical injuries that are resulting. And so those companies are doing heads-up displays using VR and AR, and those are taking hold even with older generation physicians.
So yeah, I just want to add very quick that, for the VR applications or the VR interface that, or the current hardware that it can provide like a lot of different ways to have the user interact with the virtual reality content. So it will be easier for the younger generation to adopt like more complicated inputs or something like game experience. Like nowadays, those hand controllers are designed just like those game console controllers. But that doesn't mean that that's the only way to interact. And then like later when we have our demos, you're gonna see we have like very simple interactions. And then like for most of our collaborators, clients, which are like surgeons in like 40s, 50s, they find it like very intuitive to just use it almost immediately.
Hi, I'm wondering what areas of medicine or healthcare in general do you see the greatest advancement or the greatest likelihood to adopt VR AR at the corporate space?
I think it lends itself to areas that are inherently three-dimensional. Radiology comes to mind, but I think one of the really interesting areas are things that are only possible within the realm of virtual reality. For example, like protein crystallography. There's no way you're going to see a protein other than that, in that fidelity. And the kind of things that unlocks are innumerable. I mean, we're just starting to experiment with ways that you can actually visualize, because of this alteration in a gene, it produces a protein that looks like this, and you can clearly see why it pushes a particular drug compound out, and so it's less effective. Just being able to experience the world at a scale that's only possible through that, and then as the tools evolve and you're not just observing, but you're also constructing at that scale, I think is going to be hugely transformative. And I think there's other areas like that that we're frankly not even thinking about at this point.
I'll say there's several areas in healthcare. I think one of the biggest areas is point of care. So a lot of times you'll see actually some of the new, studies coming out about VR for pain. So actually people are actually performing surgeries with VR on the patient. So the patient is immersed in the VR environment, and they actually have shown that it decreased opiate use and pain medication use and anesthetic use. And so that's actually a really cool, interesting application. They've also been using VR for phobias. So basically being able to expose them to spiders or heights or any kind of different phobias that they have in a totally immersive environment and going through desensitization using VR. So I think that is an immediate application that's already being used. I think surgical planning, I think surgical education, I think anatomical education are very interesting platforms. Again, I always think that AR and VR have to be used as their advantage as opposed to just as a tech. And so it has to be value add to that education as opposed to just being the education itself. So I think interactivity is really important. I think fidelity is really important when you're talking about anatomical and surgical education. I think there's a bunch of different areas, but also one other area that I'll mention is AR and surgery. So there has been AR planning using uploaded CTs and MRIs that they can actually overlay in the OR onto, for example, they're doing a liver resection, and you can actually see the biliary system and the vessels within the liver while they're in the OR. And so that's actually a real use that only AR could really do, and have them actually operate with AR-enabled surgery.
I can throw another one out there. I'll see if I can find the article and I'll post it out. But there was the one, it seems like such a simple use case, but from the patient side, because obviously I'm not a medical professional, but from the patient side, the one thing that I found, and it had to do with brain surgery. What the doctors were using AR for, they were using a HoloLens, and what they did is they took the scans that they do, I guess, in preparation for brain surgery, and they're showing the patient, okay, here's what's happening, here's what we're going to do with the surgery. Apparently just doing that reduced the stress level of the patients who were about to go through the surgery, and the surgeries were something like 45% more effective, because I guess stress is a big factor, and I don't really know. But the article was really cool. That's just like, okay, we can now visualize this for the patients in the, basically in prep for them to go into surgery. Here's what we're about to do, showing you in 3D. And just the fact that showing somebody that actually makes the surgery more successful is kind of, I don't know, I think it's pretty cool. But
yeah, that's patient engagement, which our surgeons, that's all they want, is be able, because like they go in and they try and explain to a patient, this is what's going to happen to you, and they're not really interested or paying attention, the outcome of the surgery could be worse. But what they have found is in VR, people get way more excited for it, and when they're excited for it, they pay closer attention, they know the risks better, and it's just a way to educate patients in a much more effective way. And I was going to say AR, but he did that.
there was way back. Moses, no?
one, are any of you picking up data from the use of your games or devices, handheld devices? Are you picking up data on a user, how they're using it, when they're using it, where they're using it, that sort of thing? And two, I was wondering, as an alternative to stateside surgeons and physicians, are you looking at emerging countries, emerging markets, remote locations where they may not be medical professionals in a sense that we understand them, but maybe they provide medical services to their local village or their local community because it's so remote, and they provide care to those people there? And what's the response from that type of community in terms of, are they receptive to doing that? Would they be more receptive than the traditional doctors? So I'll start with the second question first. So yes, there's tremendous potential as you look at global education, global surgical education. Being on a mobile device, we've been approached by several organizations internationally, one in the DRC, that has specifically asked us about using our platform for education for their local physicians. So there's a lot of interest internationally, especially when you're talking about mobile devices. They travel a lot better than a physician on a plane. And so there is a ton of opportunity in doing that, especially if you create really good self-enclosed modules. As far as the data question, yes, being on mobile, there's a lot of data that gets collected. Obviously, there's telemetry that runs through the whole time. We have a user agreement. Everybody knows what we do with our data. We don't sell it. We keep everything internal. That's all in our user agreement. But yes, there is data collected.
Trying to give it to him because he knows more about it, but we have sold tons of our legacy device in China and India, and those are countries that are really excited about this technology. Japan as well, like anywhere that the people as a whole like embrace that technology, like we can make a killing there essentially. So we've been doing that for a while. In regards to the collecting information, ours is much more like user-facing, I guess. What educators want to see is that their students improve over time, right? So if they do a lumbar puncture, you should see, we can graph, this is how close they got the first time, this is how close they got the last time. Like, that's what they're really interested in, because they want to be able to point to something and say, here are results that this person got better or they got worse. So that is really, really important to us, and it's really important to the users, so most of our software has that.
Hey, how's it going? This might be more of a selfish question, I guess, for myself, but kind of trained as an engineer throughout school and was a developer until recently in iOS and did some AR stuff and things like that. Now I'm kind of not looking to continue that path. I'm not as interested in the engineering side of it, but I'm still very into the technology and really want to play a part in the general development of that. Do you guys have any suggestions for how I could work in this market, help out or learn and further my education without the hardcore engineering part?
Yeah, so it's interesting you bring that up because my roots are really like 3D based. There's a lot of different ways you can approach doing VR and AR, and if you're not as interested in the software engineering portion, there's still a ton of UI to be defined. I think VR is so transformative right now just because everyone's kind of laying out new standards. We're all we're on our keyboards on our phones and keyboards on computers, but like we talked about earlier, there's so many different formats now to interact. I think that VR is going to need a lot more UX design and product design and also 3D modeling, because that's another form that's absolutely necessary for VR. So there are a lot of different ways to approach it, and it probably just depends also on like what you're really interested in, but you can either like make the environments or try to help define how the interactions will proceed as like a product designer or a UX designer. And I don't know, does that sound on base with you guys? I don't know if anyone else has anything to add to that.
I was going to say, go get a master's degree.
Yeah, I guess it's also and some of the knowledge or experience you gain through the university, during universities, may be like very beneficial, like even from very kind of fundamental knowledge, like math, physics, statistics, like many of our applications, for example, for surgical planning, we are actually going to need a lot of math to figure out how you want to cut bones, how you want to specify let's say draw a very complicated shape, and then you want to like automatically find out if this is the part that inside the user's drawing or outside. So there's like a lot of like the algorithm based on like the knowledge of math or physics, and then also in terms of like some like games or medical training simulations. A lot of like physics will be used to kind of simulate how the tissues should react, and then also if we want to kind of destruct something, a lot of things done in surgery. You want to dissect a tumor, or you want to do like the phacoemulsification, which is kind of like remove the cataract lens, and all those process needs, or like in some cases we don't need to tear some membranes, like create an opening on the capsule of the lens, or make a tear on the retina. There will be like a lot of like advanced physics physics knowledge that will help you to like better simulate those stuff. So yeah, like Carter said, more of those topics will be covered in some like master's degrees in different like subjects. I guess that'll be probably like good thing to consider.
So, hang on, let me jump in real quick. So, you said you're an engineer, trainings engineer? Your school's for engineering?
Well, I went for digital media and design, so
Okay.
I'm like a web designer turned iOS developer, turned I don't know what I mean now.
Okay. So the one thing I said, for all of you, I'm going to kind of go back to the raising your hands in the audience, get a little participation. Who's in the AR/VR space, like working actively in the AR/VR space right now? Cool. If you are not an engineer or a 3D modeler, take your hand down. Okay. There's a lot of people in AR and VR right now who are either 3D modelers or developers. We need marketing people, we need project managers, we need mathematicians, we need physicists, because a lot of the stuff that's happening in VR and AR is very physics related. Like you need gravity, you need bounce, you need friction. There's all these other things that need to come up. And frankly, as a developer, I'm not a physicist. So there's all this other opportunity for different fields to get involved. UI design is huge right now. We have no idea what the best way to do UI for VR is in a lot of instances where you're doing things in VR that have never occurred in the physical world before. So how do you develop the best interface for it? Locomotion, for the first year that I had this meetup, the concept of locomotion came up at every single event. What's the best way? We don't know yet. We're still figuring it out. There's probably 10 good ways now. There's definitely more good ways there now than there were a year ago. But these are all questions that have to be answered. So, ultimately the best way to get involved is to find the one piece of something that you're interested in and start going down the wormhole and just keep following it. Because you'll find something new that someone else hasn't figured out yet, and there will probably be an application for it. I have not found any wormhole that I've gone down yet that we haven't found a use for. We started digging down image recognition, and now we have our own image recognition library. Just because we're like, oh, this one kind of looks weird. Could we do a little bit better? Could we try it this way? Could we use the phone's telemetry a little bit better, a little bit differently? You go down these wormholes and you find technology that then becomes useful. It's really neat. Or user interfaces that become useful, or a new way to interact with an object, in the environment.
Yeah, I guess I was gonna say, maybe like a way to approach it could just be to try the different avenues and see which one calls to you. Because I think when you're making VR, you're gonna end up probably you have to end up in at least one of the camps where you either have to kind of be doing a lot of engineering, doing a lot of 3D modeling, or focusing really hard on the UI. And the UI is always going to be either engineering or product layouts. And then the other thing that would be worth mentioning too is the haptics and creating the actual physical controllers, which is, it doesn't sound, I guess it depends on how far away you feel from any of this, but there's a ton of space to decide how the hardware is going to function, how you're going to wear it, and also how you're going to interact with it. I still think that making controllers is something that there's a ton of room to improve on it, just because there's a lot of need to have haptic feedback. And right now, that's just one of the things about VR. It's like a little bit, there's an extra layer of complication when you're trying to weave in something haptic so that you can get more accuracy from the experience.
And then how do the developers develop for the haptic? Because these are all questions that just cascade on top of each other. Who's next?
Yes, have you read any articles about VR assisting with nanobot technology and assisting with less intrusive medical care?
Not nanobots specifically, but like we kind of touched on with remote surgery, is controlling robots for surgery is the future, and they think that VR is going to be the most intuitive way to do that, because I'll do it once in VR. It's not even like you're going to be doing it live. What I think they want is to just program it, and I guess things come up and problems happen that you need to take care of, but what they want to do is step 1 through 10, and they hit go, and the robot just does that, right? So I see that as something everyone's really interested in.
Not necessarily AR or VR, but I used to live in Dallas, and one of the head and neck surgeons, oncologists, created nanoparticles that actually will embed themselves into the cancer cells. And so during surgery, they can actually visualize the cancer cells themselves. So now he used basically maybe basically a tablet base to be able to visualize the cancer cells, but there's no reason why that display and that interface couldn't be different. It's the same concept, but it's not nanobots, but it is nanoparticles.
Sorry, is anyone else kind of just freaked out by the concept of nanobots? Anyway, we have a question here.
Alrighty, AR, VR, and diagnostics, that's one thing I want to ask you guys. Where do you see that going? The surgeries, ones that are performing surgeries, diagnostic has to take place. So AR and VR, I think, take place there, and then interacting with the patient data, and then the third part is AR and VR crowdsourcing to lead to medical discoveries. That's a lot. Hopefully that's something all of you guys can sort of contribute to here. Because my guy on the left here with precision medicine, I think we left him out when we focused on surgery. So I'll leave you at that.
Well, thank you for thinking of me. I'm very pro-surgery too. Don't get me wrong. Surgeons do lots of wonderful things. I think there's different ways you could look at diagnostics. Again, like the easiest to conceptualize is radiology, in that it's an inherently three-dimensional structure that you're trying to represent. There's also lots of, sorry, keep on. Okay. There's also lots of resistance to that, of course, because it's something that many radiologists have spent 20 years learning how to look at those slices and construct in their mind a three-dimensional object. It's also a step removed from the actual source image data. And so I think that's part of it, is there's sort of this drive within VR to extrapolate on things, and I think really what's the winning answer in that world is going to be, how do you represent the data in its most pure raw form possible, in a way that you just simply can't. It's a more pure, more direct form of the CT, for example, showing each slice in place. Looking beyond that, though, I think, again, the more interesting aspects are things that just aren't possible today. There's a whole realm of things, but in my mind, I'm thinking of organoid modeling, being able to throw small clumps of a patient's tumor and then apply fluorescent dyes that can show you if that tumor organoid is reacting to either say chemotherapy, some cytotoxic agent, or some bioengineered cell-based therapy. You're going to be able to visualize that in a way just couldn't possibly with any other medium for doing light microscopy. Thank you.
Also, this is something of a tangent. I don't know if anyone else saw this, but there's like a brand new scanning machine that can take like a single cell, and it uses like a diamond edge blade to slice very, very thin micrometer amounts of the cell layer off and 3D scan it at the same time. So it's able to kind of put together this picture of like just a mutated cell, but it's in the highest level of detail that's never been available before. And I just read this last week, so it's completely brand new. But I mean, I think that when you have that kind of evolving availability to 3D data, how do you view it? So I think that that's just like inherently right there, another idea where if you suddenly have access to brand new data that you never had before, and doctors are going to be able to look at be able to look at this and make decisions based off of this level that they've never had access to, So people might be looking at stain slides right now, but maybe in the future people will be able to be like inside of that mutated cell, like a specific mutated cell, whether it's their patient or just like a giant cohort of people to look at. So I think that, as 3D data becomes better, hopefully VR will be able to help people see it closer as well.
I'll just say, and it's not going to be a fun answer, but what the industry really wants is for machine learning or artificial intelligence to just do it for you. Like definitely being able to see really high detailed 3D models and have a radiologist or a surgeon look and be like, that's really cool. But like any one of these medical kind of like expos we go to, it's just AI everywhere. They're claiming they've solved artificial intelligence, right? So that's I think what people want. It could also just be a marketing thing. But I think as we move into the more distant future, it's going to be less humans and more like CT scans a human and the machine goes, this person has this type of cancer here, So in the short term, definitely visualization, but I think machine learning AI is going to help that a lot too.
Yeah, playing off that, I think technology-enabled medicine is basically here, and it's coming. I still think it's absolutely ridiculous that we have humans reading digital data on a screen. That's just insane. So we already know that AI can outperform radiologists in a lot of different areas. And so Bertalan Meska, who's a medical futurist, said that radiologists are not going to be replaced by AI, but radiologists who use AI are going to replace those that don't. So again, it's that idea that you can actually leverage technology as a value add. I think, again, volumetric data comes from CT and MRIs, and the idea that the software itself could render it in 3D was a totally foreign concept 10 years ago. Now nobody looks at scans without volumetric data. If you're doing surgical planning, especially for craniofacial anomalies or doing reconstructions, all kinds of different things, they're doing face transplants, all these other things, you have to take patient-specific data to be able to apply it, and visualizing that in 3 dimensions, which most surgeons do in their head, but it's so much easier and it's less cognitive load if you actually just have the picture there in front of you. So you can use that cognitive load for something much more important than trying to render things in 3D that a software can do.
I guess I just talk about a lot of things I was about to say, and which is also a great introduction to our upcoming demo. We actually have a 3-dimensional visualizations of the patient scans, and then we interact that in VRs, and it's just the surgeons find it really helpful to just explore the anatomy in a totally different way that they cannot do it in the past. They can just view it in different perspectives and remove any obstructions that has in reality. They can also zoom in, magnify the patient scans, and then they can walk themselves into it. And then they can also do a lot of surgery. So basically, the feedback from the surgeons are the VR stuff, especially the demo you're gonna see pretty soon, that will help them reduce the surgery time by understanding anatomy in advance, and also it can reduce the complications, and then we're gonna show all these pretty soon.
So, yeah, this is, sorry, we're gonna depart a little bit from our normal format where normally we just do a lot of Q&A until it's all done. We're actually gonna let them do a demonstration right now. So we'll give you guys about 10 minutes to do an actual technology demonstration. I'm gonna hand over the HDMI cable so it'll be on all the screens so you don't have to worry about like coming up here and watching things. We'll see how this goes. This is a new attempt. Are you?
Get out of our chairs. I feel bad.
Well, I mean, there's screens there's screens all over the room too, so everyone can see everything.
You guys are just gonna have to touch it.
Then how will we see it?
Use our X-ray vision.
There's 4 chairs right there if you'd like to go to the row and watch.
Just little charades, just
turn-
explain it to us.
Is one of you want to narrate or something?
You want me to talk or you want me to drive?
Either way, you can talk.
Oh, exactly, all right. All right. Is it up? Oh, I gotta look what I was looking at.
Yeah, if you guys want to sit in the chair here.
Hello? So here I'm gonna load any actual patient cases. It's from the CT or MR directly. So we have kind of a library of different cases. Which one do you want to?
The heart and spine's pretty cool. Right there in the middle.
Oh, here we go. Yeah, it's a little far away from me. All right.
So this is going to be CTA data, that's CT angiogram, which means that instead of a raw CT, which you just get hard bone, you're also going to get some soft tissue as well, which is really valuable, especially because this is used for trying to find cancer and other kind of soft masses. This is one of our biggest cases, so this is probably the longest loading time it's ever going to take. But how we market this is in the OR, if you want to scan the patient, you scan with the CT machine, load it into our software, and in about 15 seconds, this one's proven me wrong, you're going to have a 3D volume of that information. And like someone said, I'm not sure, but the most raw representation of the data that we can possibly make is what we're going for. It will work. Wow. Hear the spiel 100 times, so I'm blanking now. Oh, look at that. Okay, so here we go. So this on the left here, I think you can probably scan through it, but don't worry about it, is the actual CT data itself. So this is what we're taking it from. That's okay, just hit launch. It's also not very fast in here. So because we sell it as something that you can do, you don't have to send us the CT data and then we return processed information. We have to give some kind of cropping to the user. So what he's doing here is cropping up the surgical bed. A surgical bed is a big, solid thing that's not very cool to see in VR or helpful at all. So this is just a quick editing, and now here you can see the first kind of visualization of it. And what he's going to do is mess with this ISO value here, it's called, and what that does is just allows you to kind of isolate what you're looking for. And then we're just going to try and make it look as cool as possible. So that's the anatomy itself, and as soon as you hit start, you can view that in VR. So if you were to try it, there's a body about this big just sitting in front of you in VR that you can turn around with your hands, you can blow it up, you can go inside of it. So here you go. And like I said, trying to teach surgeons how to use this. You just say use your hands to move it around. You can try and rotate it. Yeah, see? You can blow it up really big. Yeah, so this is kind of a fun demo. So we always climb through the spine and stuff. But what it allows you to do is go inside of this anatomy that, yeah. And we have all sorts of tools. That mouse in the middle is great too. But yeah, so this is probably the hardest part, climbing. We talked about locomotion. That's kind of like the way that we decided to do it. Because everybody, if you've ever worked in VR, the first thing you say is, I don't want to get sick. I don't want to get sick. And we have to be like, the way we designed it, it's not you moving around, it's you moving an object. And if you look around, we're in a big empty space, so there's really no one's ever gotten sick in this that I've ever experienced. But that's one of the hurdles you always have to overcome as a VR developer. Is people who are like, I don't want to try it, I don't want to get sick. So yeah, and then we have some tools which allow you to try to manipulate the data. What we're really working on is what surgeons want is they want to be able to move the spine, right? For scoliosis cases, we do a lot of those, and you have a really curved spine. What they want to do is, using inverse kinematics or something, like move the spine parts back in and see how that will adjust the other things. So that's the plan for this. Can you just do a cut or something, John? Yeah, so here, this allows you to manipulate the data on a very basic level where you can kind of eliminate what you want and, you know, go for what you're trying to focus on, and then you can turn the CT overlay on, John. And that's the actual data overlaid. If you want to flip it, oh, that works too. So as he cuts it, you can have the 2D and the 3D intersected at one. We have a bunch of measuring tools, and the goal of like the measurement tools is trying to pretty much replace radiology. So if a surgeon wants to know something right now, they have to go through the radiology department and say, I need to know the Cobb angle between this bone and that bone or whatever. But what we're trying to sell to surgeons is like, put this at your desk and just do it yourself and just have it as soon as you want it. We're also working on now like exporting. If you got a case the way you want it, you could export it to other surgeons. Someone was asking about remote surgery, which we're not working on that yet, but what surgeons really want is this to be networked. So John's over there doing it, but in China, there could be someone else and he's going like, take a look at this, and like pointing with his hand, right? So essentially connecting surgeons from across the world to interact in VR in the same technology. So here's just taking some simple measurements, but it's all accurate to the data. No matter how large you blow it up, it's all on the right scale. So
basically, you're talking about multiplayer, effectively?
Yeah, pretty much multiplayer, yeah. So that's what they really, really want. They want to be able to talk to their colleagues, and right now they're doing it over the phone. You know, like look at this picture, look at that picture. But if you've ever done the VR multiplayer, it's super fun because like there's a floating head right here, and you're like, hey, what's up? But yeah, so he's doing the Cobb angle now. That's a really popular one. What else? The transparency draw, you can do that if you want. Transparency. So you can kind of see we go for really simple UIs, right? You don't have to do a lot of diving. If anyone does UX or like UI stuff, they always talk about like dive folder diving. Like we don't want you to have to dive for anything. Just like boom, it's right there, it's right there. We don't really have any words because if you've ever worked in VR before, especially the Rift, it's like 720 resolution. Like you can't read text in VR, which makes it very, very tough. So if you're looking for stuff to do and you're a good graphic designer, we're looking for icons that say like, hey, this is a Cobb angle from an icon, which is a very tough thing to do. So I give a lot of props to our icon developers who can try and get data, information through pictures. So all he's doing here is you can isolate the soft or hard tissue. So if you didn't worry about the bone at all, you just turn the bone all the way down, just focus on the soft tissue. Yeah, there. Well, turn the bone all the way down, soft tissue all the way up, would you? Yeah, all the way around. So like that. That's just the soft tissue, straight from the data. We didn't do any post-processing on this at all. And this is one of 100 cases that we have that we can load up right now. But yeah, that's pretty much it. We appreciate you letting us show you because, like somebody said, the ball's not very, doesn't show our medical ability at all, I guess.
Yeah, so, I've said this before, I've said it at pretty much every event, obviously seeing things and trying things is 100 times better than watching us all talk about it. So that's why we make it a point to have demos at every single event. I kind of like the idea of actually having a demo be part of this. We'll probably do that more and more. So that said, putting these guys on the spot right now, Level X is actually going to do a demo. We'll give them a few minutes to demo off their games on a mobile device. And then, now that you've actually seen it a little bit more, you can ask more questions. So, Yeah, sure. Get out of the way.
All right. How are you guys? Basically, oh yeah, sorry.
That's the hard part.
Yeah, exactly. So we are primarily a medical mobile video game. So all of our games are featured on mobile devices. Each time we come out with a new game, it's for a different target audience of practicing physicians. So our first game that we came out with was called Airway X, and it was for anesthesiologists. And then we had GastroX, which was for gastroenterologists. Pulmex launched last year, and then CardioX launched this year for cardiologists. So within our games, because we're primarily mobile, we try to really focus on, if we're going to use AR or VR, it has to be a value add. That experience has to be tied to AR being an experience that is important to that experience that you couldn't experience without the AR. And so we really try to focus on that. Because of that, a lot of our stuff in VR is mostly for conferences. Because we want people to experience the conference in a different way than they would on a mobile device. But because we're primarily mobile and our primary focus is trying to reach the physicians where they're at, and we're free, VR does limit the VR and the reach. So that's primarily where we use VR. Because AR is on the devices, we can use AR for a lot of our different experiences, but again, we only use it if it's actually a value add to that experience. So this is one of our AR games that we work with different partners and different clients that from industry, from societies and organizations who we work with to basically recreate some of their challenges and experiences in a game environment. And this was specifically one for Merck that is actually in the game that you can play right now. It's free to download. And so this uses AR, and it was what we call a mechanism of action game. So essentially, what they have is a medication called Bridion that is specifically a reversal agent for neuromuscular blockade. So whenever you have surgery, sometimes the anesthesia team uses a paralytic. So basically, so it shuts down your muscles. There's different kinds of paralytics. Some just stay on and are always on, and you have to literally wait time for them to wear off. Some of them you can actually reverse. And so Bridion is one of the medications that they use to reverse one of the paralytics. And specifically, the paralytic is called rocuronium, which is actually a very fast on-off paralytic, but it still takes a little bit of time. And so when anybody's having surgery, at the end of the surgery, they have to wake you up. The first thing they want to do is to release the paralytic because nobody wants to be awake and be paralyzed. That is a terrifying thing, and unfortunately this happened. So Bridion is a medication that actually does very rapid reversal. But the problem was physicians didn't really understand how the Bridion was working. And so essentially what we did was created a neuromuscular junction. And so you can see in our AR, you can actually recreate the vessel itself. And there's the neuromuscular junction. You'll see actually the medication. The rocuronium is the little green cone, and the Bridion is actually the little Cheerio-looking thing. So essentially, this is a gallery shooting game. And so as we play, you actually get combos. You get actually, I don't want to fall and die. So essentially, your goal is to try and bind the Bridion onto the rocuronium. And we actually make it a little game so you can actually get combos if you get a couple in a row. This actually gets very hard to do and talk at the same time. And you're actually getting scored on how accurate you get close and how head-on you actually hit it. So there actually is a scoring system. And the Bridion itself actually will bind some of the things you'll see yourself. So you can see actually on the neuromuscular junction, you already have the rocuronium there. And the whole point of Bridion is that once it binds enough rocuronium in the vessel, it actually creates a concentration gradient that actually forces the rocuronium off the neuromuscular blockade and back into the vasculature. And so essentially what we're going to do is to try and bind as much rocuronium as possible, and eventually the concentration gradient has changed, and now you can actually see the rocuronium leaving the neuromuscular junction back into the vessel. And this is how the drug works. So this is a good example of something that you wouldn't normally visualize otherwise, and we have it in an interactive way that you can actually understand how the drug is working and actually have a little bit of fun doing it instead of reading about it in their literature. So that's one example. The other example that I will give you guys of what we did with AR was another sponsored case that we did with Medtronic. Medtronic was basically, we're showing how to use their video laryngoscope. So when you get intubated for surgery, essentially they use a lighted crowbar, essentially for lack of a better term, to open up your airway so that they can insert the breathing tube. There is something called a video laryngoscope where there's actually a camera on the end of the laryngoscope that will actually show you the voice box and makes it a little bit easier to insert. So this is the traditional laryngoscope. It's called a Mac blade. But essentially what you do is you put it in the mouth and you lift up the tongue and the airway opens itself up. The problem is that this blade is usually good for very straightforward cases, but any complex patients, it gets very, very hard. So the first thing we're going to do is place our patient, who's really small now. I don't know why I did that. All right, so essentially, the point is that when you're actually intubating somebody with this laryngoscope, your angle of attack is extremely important. Where you're looking and where your line of sight is important. You have to have direct line of sight with the airway, otherwise you will not be able to intubate. And this is one of the first things they ever teach anesthesia folks, both CRNAs and anesthesiologists, is that you have to have direct line of sight with the airway in order to intubate. And so, as you can see, doing the direct line of sight is actually very difficult and to maintain it. And the number one thing that doctors do, anesthesia folks, CRNAs and anesthesiologists, is they look away from the cords and you lose the view and then you can't intubate. So that's actually the primary thing that happens. And then what you have to do is once you get your view, you actually have to get the breathing tube to where you're looking, which is actually also quite difficult. Wow. I did it. Okay. So then what we did was we compared that to their Medtronic McGrath video laryngoscope. So the advantage of the laryngoscope is multifold. Number one, line of sight is not important. You're doing indirect intubation because you don't have to actually see the cords yourself. All you have to do is have the video see the cords. And so it actually makes intubation quite easier, even if it's somebody who's relatively straightforward. So let's try to put them on the chair this time, so I don't have to get on my butt. There you go. So same thing. So there's a couple of advantages. One, you don't have to open the mouth quite as wide. Because you're actually not rocking back, one of the big complications that happens during intubation is you break teeth because you're trying to crowbar back against the teeth. The nice thing about a video laryngoscope is your line of sight is actually on the camera, so you actually have an advantage. Because you can see the vocal cords on the screen, it's much easier. I can stand up, I'm not crouching, direct line of sight is not important. And once you get it into a good position, actually intubating is actually a little bit easier because you basically just have to follow the path that is being shown to you. It takes a lot of hand-eye coordination. So there you go. So what we did was here was show the difference in time between using a video laryngoscope versus direct laryngoscopy. And so this was sort of what we did for them. We actually did a follow-up one where it actually was how you place the video laryngoscope was the important part, but we didn't do that in AR. Why? Because your position relation to the patient didn't matter when it's how you have to place the laryngoscope. So again, we're only want to use AR when it actually adds value. When your place in space was really important, that's when we use it. Cool. The other stuff is mobile. So yeah, your question?
Why are these in AR instead of VR?
So that's a great question. So it really comes down to the fact that, like I said before, we're a mobile video game company, and our focus is on being free and accessible. And if you have to be physically tied to a device that costs money, it limits both the free and the accessible. We are all on mobile devices that are in the physician's pocket already, and so we don't want to tie ourselves to a physical peripheral or have the cost incurred by physicians that live out anywhere in the world.
Like Google Cardboard.
So Google Card, yeah. So we can talk lots and lots and lots about Google Cardboard. Talking about nausea, but the problem is that again we don't think that everything should be visualized in VR. I think our experience doesn't necessarily have to be in VR. I've seen a lot of healthcare games where you're actually placed in the room as the part of the VR experience, and I think that that's not necessarily important. The AR, again, you don't have to have a Google Cardboard or anything like that in your pocket, and I don't think it necessarily changes the experience whether that's in VR or AR, because you're not actually creating any immersive environment that is needed. Because all you need to do is to see the virtual patient or see the neuromuscular junction. You don't have to be immersed in the neuromuscular junction.
Right.
That doesn't answer your question, I guess.
I guess what I'm trying to get at is, sorry. Yeah, I'm not understanding why, like say when you were doing the demo, it didn't matter if it didn't matter that your program recognized that there is a floor and I need to put the person on the floor, or there's a chair and the person is going to sit on the chair. So why does it matter that your software understands that there is a floor and there is a chair?
Oh, I guess can you restate the question? I guess I don't.
So I guess what I saw was the difference. What I understood was the difference between what you did as opposed to what I was thinking about when I said VR is, in your software, you made an effort to understand that in your environment, there is the floor and there is the chair, and I can put this person on the floor or the chair. And I don't understand why that is an important part of the software, that the person, that you could, instead of being in a virtual room that you could.
I see what you're saying. Essentially, the software needs a starting point, right, for where you are in space relative to the virtual environment. And so for us, wherever you place the patient doesn't really matter. I could have placed them anywhere, but it has to have a basically starting point, and so you can render it anywhere you want. And in fact, last time at AWE, JP unfortunately put it on a very shiny table, and the virtual patient actually floated away. So it does come out with some drawbacks. But yeah, it's basically just so you can set your position relative to the virtual patient. The same thing with our American Heart Association. Again, we did a collaboration with Google and American Heart Association to create a layperson's CPR app using augmented reality. And that is supposed to be rendered on the floor. But you can just have them anywhere, but your position relative to the virtual environment is important, so you have to set the patient somewhere. Does that answer your question?
Yeah.
Okay.
So now that you guys have seen some demos, any more questions? Yeah.
Hey, so I just wanted to ask, how do you see the Quest and other standalone headsets affecting the health industry? And then if you need any more specifics, just like in the next year or two.
I think it'll definitely help. From our perspective, with the visualization you saw, like we can do that now because GPUs are finally where we need them to be. Like, so it's brand new because there just wasn't the hardware to do it before. What you saw us do, we're not going to be able to do on mobile for years, I would say. We need to tether it to that PC that has a huge graphics card in it. So in terms of visualization, it's still pretty far off, but even our simulations, we're trying to get them as small as possible, right? You can probably see we brought a big case in that it all came in. It's over there. But that's a big complaint. So just like we want it smaller, so we want to get it in a briefcase. So the Quest is going to be huge for trying to get people to adopt it. Is all about making it as easy as possible to do. So when they can open a briefcase and put the Quest on, that's much easier for a surgeon than opening it up, setting up the two sensors, calibrating the room and all that. So it's just going to help adoption mostly. And when their kids get it at home and they use it and they give it to their parents, they're going to get to try it for the first time. And it's going to help all of us by advancing AR and VR in the future.
Yeah, I want to quickly add that it kind of depends on what you want to do or what does the application want to deliver. Like the application we just showed, Color I didn't bring up, this is like a patient-specific visualizations, which takes the three-dimensional data, like CT or MRs, and then we just do the straight automatic visualizations. So that needs like a lot of power. So that's for us, for the best option will be using this kind of desktop level hardware. But for other applications, for like surgery trainings or like illustrations, anything I think running on a mobile phone nowadays should be able to do it in the Quest, given the hardware in the back is somewhat similar. So I guess for some of, and another thing will be some connectivities. Quest is like a standalone hardware, so if there's any need to connect that with some other equipment, probably a computer will still be easier. Like another demo we have, the haptic device has to be connecting to the computers, unless there will be some driver that can drive the collaboration between these two hardwares. And same thing for things like lead motions, if you want to do some hand tracking. I don't know, there will be like some software out there that can take care of this, but the computer is traditionally is the hub, so kind of all these different type of input devices.
Okay.
The other thing I was going to say, so the Oculus was, crowdfunded in 2012. I think that's the year. So essentially, when you think about things being born and then how they're developed through time, the iPhone was secretly developed. No one even knew about it for about 7 years. So Apple, had it behind a curtain for 7 entire years before anyone even saw it as like a user-facing product. So I guess when you think about like the lifetime of VR right now, we're hitting that 7-year mark for Oculus, and they're just finally putting out that cordless VR headset for the Quest. So I think that in a lot of ways, we're kind of on like this frontier right now where it's starting to become really accessible, because the whole idea of the user gaining it was, it was almost premature in a lot of ways. Prior to Oculus, VR was a little bit more industrial. It wasn't as, it wasn't really user-facing. You couldn't really purchase a set easily. So I think that it will just continue to get better, and it probably needed this time to incubate, but it was incubating publicly, like where everyone could see it. And I think that that's part of why people have had like a little bit, like they lose some faith in VR or its capabilities at times, just because it's been a work in progress that everyone can see. But I think that with any new headset, there's also such a huge range of headsets available, and and obviously just using mobile or using like your iPad, whatever, that there's really like different ways to develop for any single platform. So I feel almost as though, I don't know, like, yeah, it just depends on what you want to make, whether or not you're going to find the Oculus Quest to be like this new, amazing invention for you personally. If you're focusing more on mobile, it's, it might not be your exact game changer, whereas other people who, exactly like what you guys already mentioned, carrying a headset on site, it is pretty awesome to be able to just kind of like pull it out of a bag and not have to hook everything up. So, but that's just my thought.
I think, and just like a practical application of it is collaboration. I've set up 3 wireless vibes in a room and tried to have people use them simultaneously in a multi-user application, and it's a nightmare. It's like people occlude each other's view of the beams, and they go flying, they go into ether. It's a terrible experience, especially if it's your first one in VR. And so things like that, multi-user, especially in the same area, the same play space, is really tough to do. This solves that. It solves the mobility aspect of it. It solves the fact that you can have something that you're looking at and give, let's say you're looking at a protein structure or you're looking at radiology. A lot of that, there's a lot of value in like solo applications, but you think about almost anything that you do during the course of your workday, it's collaborative. You want someone else to look at your screen, or you share them on a document. You need to do the same thing in VR for it to really transform from being a novelty to an actual tool.
And, sorry, just talking about the timeline thing really quick, because you brought up the iPhone. The iPhone was launched publicly in 2007. Yeah? That was 12 years ago. How many of you don't have a smartphone in your pocket? Raise your hand. Right. VR launched kind of publicly, prematurely, I'll admit that too, prematurely in 2016. 2016's consumer version of the product, consumer version of the Rift. Raise your hand, how many of you don't have one? Okay. When they launched, it was $500 or $600 respectively for that headset, plus you needed about a $1,200 computer to run it well. 3 years later, you can buy a wireless headset. It doesn't have to be in a fixed location, and you don't need the computer, and the price point's $400, is that right?
4 or 5, yeah.
What's that?
4 or 5.
4 or 5?
Depending on the memory.
Okay.
Entry, 500.
So, where do we think we'll be in 3 more years? How many of the people in the room think you won't have one? Or something along those lines. Let's face it, you all have a VR device in your pocket. It's, you can plug your phone into a Google Cardboard and you have a VR device. You have an AR device in your pocket. Again, well, maybe you don't use it on a daily basis right now. My guess would be in the next couple of years, you're gonna start to.
Also, Snapchat is AR. Dun dun dun. Snapchat filters.
Absolutely.
They're AR.
I'll just say, from our standpoint, that's something, trying to get stuff to run on a phone is what we do. Like, basically trying to run shaders and really high-end visual effects on a phone is what we live every single day. And we're not able to do that except for the fact that the GPUs can handle it, the graphics cards. So our games actually run down to a 6S, I think. And so if you can think about a lot of our stuff, obviously the AR doesn't, because AR doesn't come before A7?
What's up?
iPhone 7 is the thing with AR?
Oh, for AR, okay.
Yeah, for AR. But our AR will run on iPhone 7 and above. But the way that we do that is you figure out what doesn't need to be super high def and what doesn't need to be rendered in real time, and you basically take advantage of that. People do this in any kind of industry. And I know that a lot of the newer VR platforms that haven't been released, one of the ways that they do that is they basically down fidelity the peripheral vision and up fidelity the macular vision, which is what you're looking at. And that's how they can make it mobile and how they can make it more accessible, because they focus on what you're focusing on and basically down detail the stuff that you're not looking at.
There's also AMD and Samsung just recently announced a partnership. It's not
Awesome.
just
Okay.
adding to the conversation.
Who's got the next question? Moses and Beck. That helps to know some of the audience members can call in.
So before we got into the demos, we had a short comments on the future of surgery and medical procedures in terms of giving an AI a set of steps, or giving a system information or models that they can use to do a procedure. However, I work in the architecture and construction industry, and that industry has been trying to digitize for 15, 20 years. The big issue is change management. I describe a construction site as organized chaos, because things are always changing. There's a bunch of participants in the field. There's undiscovered conditions underneath the ground. So I'm trying to imagine what happens in the medical field where it's even more rapidly changing. Like, bodies aren't static, and you have things going in the body that's changing, conditions are changing. So how do you anticipate that? There's something about human beings or professionals that are able to anticipate and react to change on the spot. I haven't seen a AI or computer system that has that level of intuition to react to change on the spot and change course and anticipate what needs to happen. So that's a really complicated question. So I'll start with surgery first. There are some VR and AR applications that are trying to do basically technology-enabled surgery. And so one of the ways that they do that, because obviously the tissues change shape in real time. And as you remove a tumor, everything shifts. And so one way they do that is surface scanning. So there's a lot of really good surface scanning that's coming out. And so you can do real-time surface scanning with stuff that's being pointed at the surgical field. And you can also anticipate it based on pre-op surgery planning. So if you say, okay, if I remove this tumor, what's going to happen? And so there's a lot of things that have to go into that to try and predict things that are going to happen, and then determine when it doesn't do what it's predicted to do. And so we work with several of the clients that are trying to do that. And so it's a very, very, very tough problem. One thing I've learned working in a game studio is engineers love constant state changes. Not really, they hate it. And so it is a big, big problem trying to predict as the states are changing in real time. And one way is to try and limit the amount of variables that are changing, but humans don't follow a plan. And so basically AI is going to have a real big problem trying to predict real-time changes to therapy and real-time changes to any kind of intervention because it just doesn't have that modeling yet. But I think that's a huge struggle that AI is going to come. Obviously, if it's a static situation where it's analyzing a gene or an X-ray or a CT scan that's not moving. But imagine putting in fluoroscopy where things are moving in real time and is trying to predict what's happening. It's very, very, very hard.
Well, I mean, the other concept to that too is that AI is still, at this point at least, pretty much looking at what we tell it to look at.
Correct.
You know, so it's not, it's learning, don't get me wrong, and a lot of times it's learning in ways that we don't recognize until after the fact. I don't know if anyone, you know, like the story behind the Google Translator. The Google Translator has its own language. Basically, the AI wrote its own language because trying to translate from this language to this language and then to do it like 20 languages to 20 other languages or now 100 languages, the way it finally found that it was most efficient is it just created its own language and it translates everything to its language and then back out from its language to the new language. Now, they didn't quite know that it was doing that until they figured it out after the fact, but you know, that's where things are going to go with AI still. You know, we still knew, okay, you're still translating language to language. We don't necessarily know how it was doing it, but we told it, here's the input we're looking for, here's the output we're looking for. AI is still pretty much doing that. We're still saying, here's this information we have. Tell us if this person has cancer. Not necessarily, here's this information we have. We don't necessarily know how to define what makes a person healthy, but tell us that. But that's going to be coming eventually too.
Yeah, and a big area of medicine right now is predictive analytics using AI. So based on some of these genomic sequence or whatever their gene array is, predicting what their response to therapy would be, using basically human-derived algorithms to try and figure that out. That's a huge area because we have all this massive amount of data to try and crunch. The problem is data purity is very, very terrible in healthcare.
Dude, out of curiosity, sorry, to get away from the actual like pure medical professional, are there any nutritionists in the audience? Anyone in that area? What is the optimal human diet? Do we know this yet? Well, I mean, that sounds like, that's a very medical question, I would think. And I'm sure. What's that? Eat vegetables.
Plant-based diet.
You know, but I'm like, is it different per person? Is it different for people from different backgrounds? Is it, you know, does our genetics have a big, you know, it's kind of funny if, and you know, the reason I asked that question is because I've asked that question to 3 different nutritionists and I've gotten 3 different answers. You know, a lot of them say yes, eat a lot of vegetables, but okay, so if I eat just vegetables, is that good? Don't you need certain types of proteins that you can't necessarily get from certain vegetables? You know, this is data I don't think we really have yet.
And to that point, like for example, you know, for the longest time, you know, we think that all asthma is asthma because we said it's asthma. When you really look at it, not all asthma is actually asthma. Not all chronic obstructive pulmonary disease or emphysema is emphysema, but that's how we defined it in our own system. And as we find out more and more about diseases, we realize there's other things actually going on. Autism is a great example. There's spectrums of autism that we realize are totally different diseases, but we called them autism 10 years ago. There's constant changing of the data itself that we're using to derive the algorithms, and that's what's making it even more difficult.
Next question. Yeah.
Hi, I see you guys are marketing this towards surgery, which is very detail-orientated, like threading needle, you know. Have you guys ever tried marketing it towards something, towards like first responders or a fire department? Because I've taken a paramedics class before, and what you just did there with the, I forgot.
Intubation?
Yeah. Like we would have to like practice on a dummy, where we never, you know, and one thing they drilled in us was like, in any situation, stay cool, calm, and collected, because you're dealing with people and families on the spot in an emergency, where, I mean, I can see something like this being a great, you know, teaching tool for a lot of people that are going through these classes that will benefit from this.
You should have some screaming bystanders.
Yeah, definitely added more screaming people. So I used to be a paramedic firefighter before I actually went to medical school. So I was very involved with simulation for a very long time in pre-hospital medicine. And there's a humongous hunger for simulation and in technology in pre-hospital medicine. They are voracious with trying to use simulation. If you go to the internet, the IMSH, International Medical Simulation and Healthcare Conference, there's a ton of pre-hospital medicine folks that are there trying to figure out ways to do using VR, AR, and any other kind of technology to be able to provide education. In our apps alone, we have tons of pre-hospital medicine folks that are using it, and we just haven't really focused on those because we're really focused on practicing physicians right now. But there's absolute education opportunities across the board for any healthcare providers, for any skills. And one of the things that we really get a lot of questions about is, we're on a touchscreen, we're on a phone, and you mentioned like being in emergency situations. So your ability to process information is severely limited based on how much stuff you have to think about and have to remember. So if you know how to do a procedure, but you just have to physically do it, you can actually focus your cognitive load on doing that task as opposed to the analytical part of how do I solve this problem. If you can solve that problem before you ever have the problem, handling the problem is going to go much, much better because of several things. Number one, you've practiced. You know in your head what you need to do. The other is this concept of self-efficacy, is your confidence in your ability to perform a certain task goes up. When your self-efficacy goes up, your likelihood of success actually goes up. So if you can do pre-hospital or pre-event practice, your success is going to be much, much higher. With any surgical planning, any other platform, that's the whole concept, is trying to get you successful before you actually have to face that situation.
That was a good answer.
Yeah.
Hello. Pretty much the questions I want to ask was pretty much asked and someone answered. But I guess my thing is, actually starting off with when you showed the 3D modeling of the human body, you did the mapping of it. My thing is, if you're using 3D, I guess it was 3D mapping or 3D data, AI, and machine learning. My question on that is, to put all that together, how much data would you actually try to put in to actually try to get a representation of that model, and I guess get some telemetry of the representation of the whole human body or the skeletal, whole human structure, to go ahead and try to, I guess now, saying, okay, if you want to go ahead and say you got somebody looking at it like a surgeon or somebody doing that, they actually have actual data where they can say, okay, now I can look at this, and now this is the procedure was going on with all the different intricacies was going on within the human body to say, okay, this is how we go ahead and try to treat it. And then the second part of this, pretty much people was asking this, but what I'm going with this is on the second part of it too, of how much percent of accuracy, like I said, they do the scanning now where you use that, you have a percentage of accurate data that they actually use, which actually leads into another question, was said now, that we had this, going into VR, and I know you said right now you can't really do anything real time with it, do anything remotely, but do you see yourself in the future saying, okay, well now we can actually have somebody to assist, like have another doctor saying, I'm looking at the data coming in, with all the different technologies coming out, and I ain't saying now, but some in the future saying, you can actually have somebody doing remote, actually assisting using VR or MR, to say, okay, now we can go ahead and have a virtual patient, real time, as the surgery, whatever's being done, to say, okay, we can assist and we can actually go ahead and take care of the medical situation, take care of the medical needs. And that's the question.
Yeah, so I can answer the first part, certainly. So when it comes to collecting the data to put into VR experiences, for any of these 3D scans of the body or 3D models, I mean, it really probably depends exactly what the purpose of that application is. But medical scans, DICOM scans, you can get an MRI scan. These are actually like your medical scans of your body. So you can get those from, like, they can be personalized per a person going into their doctor to get their body or brain scanned. Or, if you're just going to insert the tube, you could also just use like a generic 3D model of the human body. That's not like specific to any single person. That should be the same each time. But regardless of any of that, I mean, if you're it just depends probably on if you're going to specify the experience, the VR application to be specific to a single person or if it's generic. But I mean, regardless, you're going to be putting 3D models in there, and then you're probably going to be like doing retopology because you'll need a different amount of polygons depending on the platform you're doing as well. So if you're going to go ahead and do a mobile experience, you're probably going to want like a model that has less polygons. If you're doing a VR headset, you're going to be able to get away with more detail, higher polygon counts, and so I think that that's like what you're thinking about maybe with the materials. And it's other than that, it's not very hard to put in like extra materials that you might need, whether it's like charts or graphs or a way to kind of, I mean, the splicing effectively is like it's like a coding function, but like that material itself is like you can, I don't know how to say this, it's not like taking up a lot of the memory to like show like a DICOM scan, if that makes sense. But yeah, that's what I'd say about the materials. I don't know if anyone else has something to add.
Less draw calls, basically, for less materials.
Yeah, exactly. Like you gotta just kind of balance it out based on what your goal is versus what the capability of your platform is.
Well, I'll just say, what you saw is, she mentioned DICOM. We can load DICOM as well. That's just raw data that gets loaded in. The problem that we have...
What is DICOM?
Digital image communication, blah, blah, blah.
Yeah, it's just a file.
It's a file format for radio.
But the downside of that is that our representation of it is only as good as the original scan. So if the person twitches in the CT machine, it's going to show up as noise in ours. And that's where it's going to be like, what we're going to need AI for is removing the noise. Because these machines, they just have a ton of it. And if you remember, when he slid it back and forth and it showed more, this keeps doing weird things, that's kind of a manual way to try and get rid of noise. So, and this kind of goes back to the question we asked earlier about like how do we get this to be predictive? Like everything else that we do, it depends on the hardware, right? So when new scanners come out, somebody just told me at work that like they have a new CT scanner that can scan mid-operation, right? So depending on how safe it is, maybe you hit somebody with that every 30 seconds and we rerun it, and that's, you know, AI will obviously be the best. It would be awesome if it was all real time. But in the very near future, it's going to be like, you know, maybe every 10 seconds you got a new frame.
Right. Question I want to ask this, and I'm sorry.
It's okay.
Again, I think you pretty much hit it. And in the near future, hopefully, like I said, we come on going with surgery. That basically you can't have a scan, you can be scanning them at the same time, real time. So you got the surgeon that actually perform the surgery and so forth, but you may have some assistant surgeon there looking at the VR image or VR representation of the person at the simultaneous.
That's just what some of our coworkers do. That's their jobs. They're in the OR, and as most of you know, surgeons have to like scrub in or whatever, and they can't touch anything after they've done that because the patient could get infected. So instead of de-scrubbing and looking at it, one of our employees is there is going, turn it over, blow it up, cut this part off, right? So like that is something that already exists, and it's obviously very, very helpful to not have to come out of your surgical scrubs all the time to try our software or use it.
Yeah, I'll add, I 1000% agree that your data is only as good as the source, right? So if you look at MRI data, you can have the same scan done in 1.5 Tesla versus 3 Tesla versus 4 Tesla. The image quality is going to be completely different. The size of the file is going to be completely different. And the amount of surface retouching and the amount of editing and cropping you're going to have to do is very different. Also, CT scans come in a bunch of different slice sizes, right? So you can do 1mm slices, 5mm slices, you can even do 10mm slices. And all of that is going to affect your 3D rendering that gets outputted from that source data. And you don't really have control over what you end up putting out unless they know the specific reason you're going to be using that data. So you're basically behest to whatever they give you. So when you're talking about patient-specific scans, it is highly dependent on what is the source technician setting the actual scan at, and what type of device are they scanning, less so what kind of format, because they almost all come out in DICOM. The other question you had was about telesurgery, or essentially telepresence, right? So having another surgeon who's virtually in the room. So neurosurgery is a big proponent of having CT and MRI in the room. So a lot of times what they'll do is at a certain point in the surgery, they'll stop, they'll put the patient into the MR in the OR suite, and then take them out and they'll re-update the images based on what he was saying is they can now render it again in 3D and see, okay, now that this part of the tumor's out, what does it look like? And they can get that in real time. The problem is this, if you've ever, who's had a CT or an MRI? who got claustrophobic in the CT or MRI, right? So it is a massive machine. So until we can get CT scans and MRIs that can actually perform their function, A, in a very, very small space, and B, not using technology like radiation or magnetics, you're going to be severely limited to what you can do in real time. So you really can't. The only real-time imaging that we actually do is fluoroscopy. So fluoroscopy is basically just putting your foot on the x-ray machine and having it going every 5 seconds. But again, that's a huge radiation dose to the patient and everybody else in the room. So otherwise, you can't really do real-time imaging during surgery except for fluoroscopy right now. I think telehealth and telesurgery and telepresence is really freaking cool. I think telepresence is going to be one of the coolest things that's going to come, and actually being able to be a surgeon in Ghana and having another surgeon who can actually telepresence into the OR. Google Glass had this promise 10 years ago, right? Google Glass promised to have surgeons across the country to be able to have you help operate in remote conditions. And Google Glass, I heard, is making a comeback.
I've said this before, it never really went away. It just went away it wasn't public. They've been using it in manufacturing. They've been using it in a lot of use cases like that. It's not considered consumer products, but now.
So a lot of people, there's actually been a bunch of different surgeons that use Google Glass basically for real-time displaying of their surgeries. And so, obviously with the patient's consent. And so other surgeons can actually watch that feed and tell them, hey, no, move a little to the left, no, move a little bit to the right. The question is, does AR and VR have that capabilities for another surgeon to be somewhere else using telepresence to be able to be in the OR with the original surgeon? That is going to take some time. Back to the other question of the fidelity or the connectivity and the speed of the Wi-Fi is very paramount to that.
So, oh, sorry.
Just the one thing, they don't even have Wi-Fi in the OR. Everything goes through this thing called the PAC system, because it's all security, right? It's just patient data. They can't, so like when we want to update our apps, like we have to go jump through a bunch of hoops just to connect to our PCs that are in the field. So, and as you can imagine, the technology in the hospital is not brand new, you know, their database and their connectivity. So it's, everything in medicine is jumping through hoops, but we're trying our best.
So we'll do one more question. Before we do, next month, we already know our topic next month, which is actually kind of cool for this event because we sort of, do a lot of stuff last minute recently, but that's changing. Topic next month is going to be law. And we're looking at law with VR and AR on 2 fronts. Obviously, one of the, we're going to be talking about intellectual property. That's a big thing. We're going to be talking about companies trying to actually get started in this space and what they need to be aware of. So if you have questions for lawyers, there's going to be several of them up here that you can ask. So we will have a very specific lawyer up here who is a startup lawyer who can answer all those types of questions. We will have an IP lawyer up here on the stage, and we will have a gaming lawyer up here. We're going to tackle some really fun topics like, the one that I brought up recently is, I don't know if anyone saw the Burger King app that will like burn their opponent's marketing materials on billboards. Yeah. That's kind of a big liability question, isn't it? So we'll see where that goes, because we're going to ask all the lawyers about it, because technically, the other store, I won't name them, but they probably paid for that advertisement. They paid somebody who owns a billboard. That billboard is a physical space that somebody owns. There's a graphics company that designed the ad, who owns all that IP and the ability for someone else to just hold an app up and say, hey, let's burn that. Even if it is virtually, there's a lot of questions about that. There's the Pokemon issue from Milwaukee of, is Niantic liable for all the people who are walking around the park in Milwaukee and trampling the grass? Which the answer was no, they weren't. But at least that one was settled. But these are all sorts of questions that are coming up in virtual space. If I develop software and someone else is playing my software at an event where they can't see and they walk off the stage, who's liable? Is it the location? Is it the Oculus? Is it me because I wrote the software? Or is it the person giving the demo? These are all really fun legal questions that need a lot of answers, and they're going to deal with VR and AR. So we're going to start asking them all next week. Next month. So that will be the topic next month. We are trying to get a little bit more advanced in our planning. We actually have most of our panel already booked, which is kind of cool. We're going to have some cool demos. If you are interested in demoing at our events, please reach out to us. We'd love to have you here. If you're interested in volunteering at our events, please reach out to us. We'd love to have you helping out. Other than that, I will turn it back over for one more question, and then please try demos. Because I've said this before, I've said a lot of times, you will learn a lot more 2 minutes demoing things than you will 2 hours of listening to us. Last question was there.
All right, I hope this is
Microphone,
beneficial
please.
to everyone. So my first question is, what is the name of the gaming, was it app that's free? Was it Mercs or something? What was it called?
All X games.
Our games?
Yeah.
So our company's called Level X, but each one of our games is specific to the target audience. So Airway X was the one that I had that had the AR units in it. Those were sponsored cases for anesthesiologists. So it was our Airway X, but we also have Cardio X, Palm X, and Gastro X.
And did you say they were free?
Totally free.
Now, what incentive do you have, or how do you monetize on that if it's totally free? And
So,
why is it even out there?
That's a good question. We want people to have fun. Yeah. So at the end of the day, we're a video game studio. We're trying to create really fun experiences, leveraging people's real life skill set in a game environment to see stuff that they would have never seen otherwise. And so that's really kind of our ethos. And our ethos is also trying to be free and accessible, so that's why we're on mobile. The way that we monetize is because we basically partner with different associations, societies, and industry to be able to create those sponsored cases, and that's what gives us the funding to be able to continue to make free content for our physician user base.
Okay, so do you allow other startups to use your AR, VR for their own benefit? Like, I currently work with entry-level college students who really need an idea of what it's like to be a surgeon. And I think having that ability to go into that game and just kind of give them a 60-second look at what it might be like.
Absolutely. My friend's a real estate agent and calls me and tells me how many polyps he got today. Literally, because it's free, anybody can download it. Now, because we are targeting practicing physicians, there's a little bit of a difficulty gap. It's not really scaffolded for novice learners. And so when you go into, for example, a cardiology app, really it's made for cardiologists, and really it's actually made for interventional cardiologists.
Okay.
Even some cardiologists can't play the game. Now, the tutorial takes you through how to do what you need to do in the game. It doesn't necessarily tell you how to practice medicine.
Okay. Do you guys have that at all in any of the games? Do you have anything that's kind of premature, per se, for someone who wants to go into maybe medicine? Is there possibly a game there that exists that I can help show the students and say, hey, we want to help you guys get to that level. We want you to be doctors. We want you to be lawyers.
Really any of them. So our team has done, our game designers and our engineers and artists have done a phenomenal job of creating a tutorial that most anybody could really get. They don't necessarily understand what they're doing. I would say Airway X and Palm X and Gastro X are much more intuitive than Cardiology X. The reason why is Cardiology X is essentially looking at a fluoroscopy image that nobody has any concept of what it is. Whereas Airway X and Palm X and Gastro X is literally a scope in a tube that they know what an esophagus is, they know what a trachea is, they know what a bronchus is. Or they can, and the game is scaffolded in the tutorial sections to understand how to do what you need to do. And each game has a different amount of challenges, and I would say start with one of those three. Cardio X is not really made for novice learners.
Yeah, download it and try it. I've tried it, it's hard.
I tried it. Okay, thank you guys.
Yeah.
Any other questions? Do you guys have any other final statements you want to share? Anything else about just like where this is going? What you think is the next kind of big step, I guess? Or something you're excited about that you guys want to talk about? If you can. Go.
All right. I'm gonna pull that out of my head right now. Where is this going? For me personally, I am really excited to have access to 3D models that we've never had access to before, and I'm excited for people to be able to learn more actively. I just think overall that, especially in an industry as complex as the biomedical industry, this is going to present a way to digest information more quickly, remove some of the burden of decision making or just having to analyze data more through that 2D format when it's just more accessible and understandable through 3D. And there's a lot of studies that do show having access to 3D information and haptic feedback, it really increases the brain's ability to learn. So I think that whether you are a physician or whether you are just a person who needs to learn more about what would it be like to be a physician, The chances that you'll be able to actually genuinely learn and have genuine insights with VR, I think it's a really amazing potential, and I think it's a lot higher than, in certain ways, you know, in certain aspects, you can have a lot higher chance of genuine learning through 3D. It's sort of like if the real world was crafted to help you learn, but it's not all the time, so you can just use a virtual experience built to help you learn something.
For me, you know, I'm exactly what you said, but I think that there's tremendous opportunity in VR and AR. We haven't realized it yet. And my ask to everybody in this room who's interested in VR and AR is think outside the box. Think about ways that we can use VR and AR as a value add to some experience that people have in real life that they want to learn more about. My only ask is do it if it only is a value add. VR is starting to get a very bad name in healthcare, I promise you. And the reason why is because people are putting 2D animations in VR and AR, slide decks. This is horrible applications for VR and AR, and it's getting a bad name. And as we talked about earlier, physicians and surgeons are traditionalists. They are Luddites. And if we do not prove to them that VR and AR actually has a real application, it's going to be really tough for us to move forward. And that's my only ask is please use it properly and use it wisely. Technology does not replace the education. The education has to exist, and then the VR and AR has to be designed as a value add to that educational objective.
It's a great point that the purpose of the VR, AR will be like adding a value to what we already have in life. And then I think maybe like everyone on the stage are maybe sharing like the same type of like excitement that we can use the technology skills experience we have in the field of VR or AR and then apply that to the industry of healthcare and to improve people's health, well-being, and potentially save lives. It's really like a very fascinating, exciting experience, and then like it really like that shows like this is like one of the potential of the VRs, but really like a huge motivation to us. So I guess I also want to add quickly at the end of this event that if there's anyone in the room or anyone like live on the stream that will like to join the same type of like excitement with us, give us a call and email. We're hiring, so just we'll welcome all the people who are interested in this.
I think we're at a really exciting tipping point. We're all here because it's intuitively exciting as a medium. It's necessarily going to work. It is a higher bandwidth of information than you can get any other way. There is a lot to figure out, but we are at a significant point because it's no longer inaccessible. And that, besides just more devices being out in the world, means there's going to be more developers investing in this. That means there's going to be more enticing games. It's creating a virtuous cycle that will bring more people into the ecosystem and just ultimately bring more and more minds into this ecosystem. They're going to solve these difficult problems, the interaction problems, the rendering, computational problems, and it's going to create so much more opportunity for healthcare and really any other application. And we'll probably get some crap to start out, but that's probably true of any technological revolution we can think of. So I think we're all probably here because we like things that are new. We're early adopters, we're pioneers, and that's exciting to us. And this is the time. This is the renaissance of this medium.
Yeah, everyone pretty much said what I was going to say. It's just like if you're here because you're interested in being a VR or game developer, like if you start now, by the time VR breaks through in a couple of years, you'll have 3 years of experience on everybody, and that'll be huge. You know, so like if you were working in web dev or something and you didn't like it, I went to school and I got a database management. I was just doing database stuff all day.
And I didn't want to do that until I found game development, which is super fun. It's like the most fun in the world. I love going to work every single day. And I don't have an education, use YouTube, go to Discord chats, do whatever you want. Just like, you can learn this or teach this to yourself really easy. You don't have to go get a master's degree like this guy. You can just like, yeah, he might be a doctor. You are a doctor, aren't you? Yeah. So yeah, I'm just saying, I don't have a degree in game development. I had an interest in it, and I used to come to these things, and that's where I met someone who had a HoloLens, and it just kind of started me on the career path I'm on now. So, go for it.
Yeah, really quick, I'll close this again along those lines. I have a psychology degree. Like, I don't think I've ever taken a development course. I took one, sorry, I dropped it though. Basically, seriously, I've never taken a development course. I've been a professional developer for my entire life, or my entire adult life. It's, teach yourself this stuff. It's pretty easy, it's pretty accessible. That said, someone else just nailed it on the head. The web had some crap when it came out, let's face it. Okay, it did. We are in, I've said, I liken where we are right now with VR and AR to the web in the early 90s. This tech is here. It's not going away. There is a new way to communicate information that you cannot get through existing mediums, and that medium is AR and VR. This is not going to go away. This is basically the next computer interface. And so, for the people who are grasping that now and starting to realize now that this is the way that information is going to be communicated, the whole topic that I gave in January was this is the next evolution of communication. This is how we're going to deal with data for the next 10, 15 years, at least until something else better comes along. I don't really know what's going to be better. Singularity. But anyway, that said, we'll end it here. We still have time in the room, so please try some demos. Talk to these people and actually ask their one-on-one questions. If you're afraid to raise your hand and get the microphone, we know that happens, it's fine. But look around, you talk to other people in the audience. Obviously, everybody in here is interested in this technology. We've already had one person on stage say that they're hiring. That's always a big topic that comes up. Pretty much every time I've done this event, there's been at least 2 or 3 people who've come up to me and said, hey, how do I get a job here? Talk to the people who are hiring. That's the easiest thing to start. Please, it seems really simple, but just do that. Alexa's hiring. They're actually, you are your recruiter here. There'll be recruiters here at almost every one of these events, so just talk to people. A lot of times, they're not up here, they're out there, and I don't know about it ahead of time, so you gotta talk to yourselves too. But anyway, thank you for coming. Again, next month will be July 10th? Sorry, so next month is July 10th. It's not the first Wednesday. Normally we do this on the first Wednesday, but the day before a holiday, we kind of wanted to switch it up a little bit. So next month will be July 10th. The topic will be law. Thank you for coming. Please, the pop is there, so drink the pop and water, whatever, drink that stuff. Otherwise, they just donate it to the space. Thank you.
And thank you. Good night.